Okay, we're back, and we're still talking about the first stage of labor, which we know is broken into 3 sections. We've talked about the latent phase. Let's see, where are we? The latent phase, the active phase, and now we're in the transition phase. We're going to continue to encourage voiding every 1 to 2 hours, again, to get that bladder out of the way of the delivery, of the baby being able to come down and out. Excuse me. And however, we are not going to encourage voiding if they have had an epidural. If they have an epidural, we know we've anesthetized the whole area, and therefore they will have a catheter. Otherwise, they're going to be, urinating all over themselves. Encourage a rapid pant flow breathing pattern, which we're going to talk about in the pain section of this module. If the client has not learned a particular breathing pattern prenatally, anybody can do that. All you have to do is know how to count. Discourage pushing efforts until that cervix is fully dilated, or we're going to have big time problems. It has to be at 10 centimeters. And listen for client statements about having a bowel movement. All that means is, again, the uterus is in between the uterus and the rectum. So when that baby's head's down there, it's putting pressure on that lower bowel, and it feels just like you're going to have a bowel movement. Very, very similar, the pressure. Observe for perineal bulging and crowning, because that means the head is there. And encourage the client to begin bearing down, using those abdominal muscles to help push down on that uterus and move that baby out once the cervix is fully dilated. Again, for transition phase, the cervix is going to be 8 to 10 centimeters, cannot start pushing until they're at 10. Frequency, the contraction should be about 2 to 3 minutes apart, and duration lasting 45 to 90 seconds. So they're starting to be on top of each other. May have mother lie on the left side. Again, whenever they lie on the left side, the pressure's off that inferior vena cava coming back to the heart, so it's a better blood return to the heart. Okay, now second stage nursing assessments, and of course this is what I call showtime, because the baby is coming. And vital signs every 5 to 30 minutes per hospital policy. Again, we know if they're high risk, they're going to be every 5. If it's a normal delivery, every 15. And it depends. If it's normal and everything's been fine, but all of a sudden there are a lot of late decelerations, what's the cord doing? What's the baby doing? We may increase that to every 5. Assessment of every contraction, of every pushing effort, of an increase in bloody show, because that means the mucus plug is now open, and that's, holding that cervix tight together, and all the contents in the uterus. Obviously cervical dilation, because we know it can't come out unless that door is open. And here it is. Assessment of fetal heart rate continuously every 5 minutes and immediately following the birth. Assessment of perineal lacerations, which occur as the fetal head is born. Just a tidbit of information here, which it helps make sense about the tears, is that most babies, even premature babies, can have a 32, 31 centimeter head. Normal centimeters for the circumference of a head, which is the entire, the widest part of the head, is going to be anywhere between 32 and 38 centimeters, depending on how big the baby is. Well, we have a cervix, which is the door that needs to open to the uterus, that is only going to open 10 centimeters. So do you see how the bones have to flatten down and lie on top of each other to get out? Some of the second stage nursing interventions, again, continuous client and obviously fetal monitoring. What are the vital signs doing? What does it look like? What do the tracings look like? Assisting in positioning for effective pushing. Assisting in coaching, especially if there is no coach, and sometimes we have to teach the coach, and sometimes we have to be the coach. Promoting rest between contractions. The biggest deal here is we need that mom to be able to re-oxygenate herself so that the baby is not compromised. Comfort measures such as cool compresses. Sometimes there's no time for that, but sometimes that's good. We don't want hot compresses. That promotes bleeding. We know heat dilates. It also, the mother's very warm. It doesn't matter how cold everybody else is in the room. They don't call this labor for nothing. It's like when you guys go out and work in the yard or work wherever, and at first you're cold, and then all of a sudden you're taking You're taking garments of clothing off because you're warm, because you're working. Cleanse the perineum as needed if fecal material is present. Remember that uterus is right in between the bladder and the rectum. And so sometimes putting pressure on the rectum, the mom will automatically, in the pushing efforts, fecal material will come out. Nobody makes a big deal about it, or they should not. Very unprofessional. You just wipe the area clean and we'll proceed on with the birth. And then provide feedback. And that is so important about being a coach, being a cheerleader, helping everybody in the room. And you all will see that when you're in the rooms. You're going to tell them, yes, I can see the head. Keep going, keep going. And it's going to help them deliver that baby and do well with that. So the third nursing assessment, so now the baby is out, and the third stage of labor we know is the placenta. Not as exciting as the baby, but there's several things that we need to look for and do. Vital signs, again, are going to be not every 30. We're going to assess for signs of the placental separation from the uterus where the fundus is firmly contracting. Sometimes there's a swift gush from the introitus, which is the opening of the vaginal, dark blood. The umbilical cord actually looks like it lengthens because it's all coming out. We know the umbilical cord is attached to the placenta. And then at this time, we're going to assign the 1 and 5 minute APGAR scores to the newborn. And that's usually on all of the walls of the delivery rooms now. That tells the cardiovascular status of the infant are those APGAR scores. Instruct the client to push once signs of the placental separation are indicated, meaning we can see the cord is lengthened. We're having that gush of blood. And sometimes you'll actually see a globular, like you'll see something moving in the uterus because the placenta at the end is fairly good size. Sometimes it takes up half the one side of the uterus. And so, but a lot of times you do not have to instruct them to push. Sometimes you guys, it just follows the baby right out. It's nothing like delivering the baby. Absolutely nothing. Promote family infant bonding. Administer analgesics as prescribed. Most of the time at this point, all the contractions have stopped. They don't need analgesics unless they're having to sew them up from a tear. Oxytoxics as prescribed. And all that is, oxytocin is Pitocin. And it's going to help contract that uterus. And you're like, well, wait a minute. I thought they gave them that to get the baby out. Well, sometimes they do. But we know it's going to contract the uterus. And now we want the uterus to continue to contract, not like it was, but definitely to involute or contract down because there's a lot of arteries that are wide open. And remember, one of the biggest reasons why women die worldwide, if not the number one reason, I have to look at that again, used to be number one, is that they hemorrhage after childbirth. And breastfeeding is known to, breastfeeding helps contract that uterus, and that's why very, very important. It took us years to figure this out. I don't know why, but put the baby to breast actually helps with a normal letdown of oxytocin, endogenous from the pituitary in the brain is that breastfeeding. So women are bleeding, the baby needs to go to the breast. It needs to go to the breast anyway for bonding. Okay. Fourth stage is basically our recovery. It's OR. They can be, if they're OR, fourth stage may last a little bit longer from a C-section. In fourth stage, with a regular vaginal delivery, as soon as that fundus is pretty firm and tight, and we've got probably 4 sets of vital signs for the first hour every 15 minutes, they're stable, they will be sending the mom. Maternal infant vital signs, what does that look like? The uterine tone, is it stopped? Is the bleeding stopped? The lochia, and that's the drainage that comes out, and we haven't looked at that yet, but it's called rubra, lochia rubra, in the first, immediately after birth up until 4 to 5 days, and that's bright red. It can get a little bit darker as the hours proceed after the delivery. And of course, maternal bonding, which that golden hour we're talking about now, where the baby goes right on mom's skin to skin. We'll put a diaper on and maybe a blanket over both of them if it's cold. Interventions, again, massage that uterus, the uterine fundus, administer the oxytoxics, just like I said, as needed. Encourage voiding. Usually that catheter comes out right away after the epidural. but only after the legs come back. Once we know the legs work, then the medication in the epidural has worn off. And I bolded this. Always have a client walk to the bathroom with the nurse after delivering the baby. Always, always, always. They've lost a lot of fluid. They can become extremely hypotensive from that. I can't tell you how many women I picked up off the floor, even after you've told them, do not get up without me, or they're on top of the husband or the significant other because they're trying to help them and they know you're busy or you're in with another delivery, so forth and so on. But even if they haven't had an epidural, I always say you have to get up one time with me because they can get very, very dizzy. And, you know, just like our hypotensive people in med-surg, we're going to have them swing their legs around and dangle before they get up. Okay, I'm going to stop right here and we'll finish up with lacerations. And we're almost done with intrapartum lecture. I'll be right back.